Hey, hello everyone, and welcome to IBD in Focus. This is the second of a three-part virtual education series for Crohn's and colitis patients. I want to thank all of you for joining us tonight, and I also want to thank our sponsors, Takeda Pharmaceuticals, Janssen, Gilead, and Pfizer. And I also want to thank our amazing volunteers. It's such a pleasure to work with so many volunteers that are passionate about finding a cure for Crohn's and colitis and improving the lives of patients. And we're going to hear from some of those volunteers tonight. And starting, we're going to have Dr. Parakkal Deepak from Washington University School of Medicine. And Dr. Deepak, welcome to our virtual stage. Would you like to share your screen?
Sure. Thank you, Dan, for the introduction. I think I'll get started since let's see, hopefully I don't run into any technical issues. Actually, 1 second. I think get into presentation mode. Sorry. Okay, let's see.
Take your time, Dr. Deepak. He is also on our medical advisory committee. So Dr. Deepak actually helps us plan these virtual education events, and hopefully someday soon we'll be having education events in person again. And they're a lot of fun. You get to meet other patients, and we usually have a meal together and hang out and have a social afterwards. So looks like I can see your slides now, Dr. Deepak. You are ready to go.
Perfect. Thank you. So I'm Dr. Deepak, as Dan introduced, at Washington University IBD in St. Louis. And the topic I picked to talk about is a topic which is very current, relevant, and also something that I think every single day in clinic invariably is a question. So I think I want to talk about this, share some thoughts, facts, and then of course take lots of questions at the end. So the topic is COVID-19 and inflammatory bowel diseases. Here are my financial disclosures. So the talk I divided mainly into 4 parts. First, very briefly, a general COVID-19 overview that I'm sure everybody in the audience at this time has heard many times over in the news, in the print, social media, everywhere. It's kind of hard to escape this. COVID-19 and GI tract is the second part of the talk. Third, a question that is asked every single clinic: are IBD patients at an increased risk? And look at some of the studies published in this area. And then if time permits, a few slides on the expert consensus recommendations on managing IBD in the setting of COVID-19 during this era. So COVID-19, as everyone's well aware, is a clinical disease caused by this novel virus called the SARS-CoV-2 virus. This, as again everyone's aware, is a pneumonia of unknown origin that started in Wuhan, China around December 2019. And coronaviruses themselves aren't really new. They've been around for a long time. They have been known to cause upper respiratory illnesses. That said, this particular virus, SARS-CoV-2, is a new virus not previously seen in humans. It is similar to certain other epidemic strains that have occurred in the last 10 to 15 years, such as the MERS-CoV and the SARS-CoV-1 virus. And it appears to have potentially originated in bats because they did some genetic studies of the virus, and it appears to be fairly close to the sequence in bat coronavirus. The clinical course of this illness can range from mild illness to more severe organ dysfunction that can lead to death. Luckily, I would say most cases of COVID-19 appear to be mild, which is around 80+% of the patients who acquire this illness. Clinical deterioration can occur during the second week of illness, taking around 5 to 8 days from initial onset of symptoms to the development of shortness of breath or the need to go to the hospital and be admitted. Among hospitalized patients, around 5 to 33% of the patients have required admission to the ICU across various studies. And then a number 6% has been listed as a case fatality rate per the Johns Hopkins COVID-19 dashboard. This number obviously can change depending on the study we're looking at, and also may change over time as we get better and better at managing this illness. The symptoms suggestive of COVID-19 include well-known symptoms at this point, such as cough, shortness of breath, or difficulty breathing. Or patients often have two of these symptoms, which can include fever, chills, repeated shaking with chills, pain, muscle pain, headache, sore throat, and this well-described symptom of new loss of taste or smell. These patients often also have known exposure to infected person, may have an abnormal chest X-ray or a CT scan of the chest, and have additional lab abnormalities including lymphopenia and elevated inflammation markers such as a C-reactive protein. But what about GI symptoms? So let's get into that. So the GI symptoms have been reported in patients with COVID-19. This particular study highlighted on the slide is one that was published in the premier clinical journal in the field of gastroenterology, also called the Gastroenterology Journal. What they did here was that they took a large number of studies that were already published at that point, took all of their data together, and then kind of did a summary of that data. So what did that show? It across 60 studies and over 4,000 COVID-19 patients from 6 countries, GI symptoms were reported in around 17% of the patients. And these can be as listed on the slide: just not feeling well and not wanting to eat, called anorexia, diarrhea, nausea and vomiting, or having abdominal pain or discomfort. What they also noted was that severe COVID disease was more common in patients who had GI symptoms compared to those who did not. It was also relatively rare, but possible, where around 3% of the patients had only GI symptoms without respiratory symptoms, but most of them did have a fever. Now, this is significant where someone, especially with inflammatory bowel disease presenting with a fever and diarrhea, is often a symptom of active inflammatory bowel disease. But in this COVID pandemic period, this could also be a symptom of COVID-19 infections. So that is something that requires then careful analysis and separation. Now, this is a complicated cartoon. The only takeaway from this I wanted for the audience was that there's a receptor called the ACE2 receptor, or the angiotensin converting enzyme receptor 2. And what this is that ACE2, as shown here, if you can see my cursor, is almost like a gateway for this SARS-CoV-2 virus to enter the lining or of the gut. And this is a receptor that is expressed in the gut. So there are studies ongoing looking at whether the gut is one of the gateways for the virus and leading on to further illnesses. Obviously, the presence of GI symptoms suggests that this may be a possibility. And especially this may be a factor in those who have more severe disease. And this is an area of active investigation. So then getting into, are IBD patients at an increased risk? This question is important because management of IBD not always, but often involves use of immunosuppressive or immune modifying therapies. Also, previous studies using many of these therapies have shown an increased risk of some viral infections, such as influenza or the flu. The VZV virus is the one that produces chickenpox or later in life shingles. There's other viruses such as CMV. There's also those that cause liver inflammation or hepatitis. There's also concern about exposure to healthcare facilities because IBD patients do receive infusions in infusion centers. They also may require routine investigations such as labs, imaging studies, or diagnostic endoscopic procedures. Finally, as I mentioned before, the bowel lining does express this receptor ACE2 that can act as a gateway for the virus to infect the gut lining. Now, this particular point is an area of active investigation to ascertain, does this happen in every patient or does this happen only in patients with severe COVID-19 infection? So what about COVID-19 in immune-mediated diseases? So this slide shows a case series that was reported from the New York City of 89 patients, of which 59 patients were confirmed by the nasal swab with what's called as a PCR or a polymerase chain reaction, which is sort of the gold standard way to diagnose COVID-19 infection. This was the earliest study published in immune-mediated diseases in the New England Journal of Medicine. What they showed here was across patients with rheumatoid arthritis, IBD, psoriatic arthritis, and certain other rheumatological conditions. 72% of the patients were on immunosuppression. Now, if you look at the table, they looked at various immunosuppressives such as hydroxychloroquine, methotrexate, and steroids. Now, to my far right, and where my cursor is lying, you can see these numbers 1.43, 1.37, 1.4. So what this would suggest is that all of these were above the number 1. So there was maybe like a 40% increased risk of COVID-19 outcomes mentioned here with these particular medications. What they did find, however, was that around 16% of the patients were hospitalized, which was quite similar to the overall rate of hospitalization in New York City at that point. So this was the earliest data that suggested maybe immune-mediated disease patients were, the risk was probably similar to that of other patients in New York City, however more data was needed. This led to this really amazing international effort to better understand COVID-19 and IBD. Now, this is called as the Secure IBD Database. Secure IBD Database is something that anybody can Google on any kind of browser, on their phones, laptops, any device you prefer, and they can actually see the data that's publicly available, what's been reported currently, and what does that look like. So what is Secure IBD is that it's a large international registry of IBD patients with confirmed COVID-19 infection. This was started with two main aims. One was to define the impact of COVID-19 on patients with IBD. The second was to evaluate associations between the age, various comorbidities, and by that I mean hypertension, diabetes, high lipids, cardiovascular disease, lung disease, and in the setting of an IBD patient, any IBD disease specific reasons that may impact COVID-19, and any impact of the IBD treatments on COVID-19 outcomes. What did this study show? Now, I have referenced the study down here at the bottom of my slide. This was done by Ryan Uncaro at Mount Sinai in New York, and this published in the Gut Journal. As far as I understand, this study is freely accessible because some of the authors on this had funding from the National Institute of Health. So for those who are interested in more details, are very data oriented, this is available if you again search on Google or on Google Scholar, and you can see more. Now, I have taken some of the data and put them in these slides to discuss today. So there were 1439 patients or cases at the time of this paper reported from 47 different countries and 39 states within United States. The mean age of the patients were around 44, 51% were men, and 55% had Crohn's disease. What's also interesting is that a majority of patients were in remission at the time of the infection, and then most were either on TNF alpha antagonists, and by this I mean things like Remicade, Humira, Cimzia, Simponi, those kind of medications that block TNF alpha, and others were on mesalamine or sulfasalazine. Now, the outcomes are shown to the right on the slide. Around 1 in 3 patients were hospitalized. And a key outcome studied in this was the severe COVID-19 outcome, which was present in about 112 patients or 8% of the cohort. What this was a composite or a combined outcome that composed of either requiring admission to the ICU, and not just to the general hospital, but to the ICU, or requiring use of a mechanical ventilator or a mechanical way of um, supporting respiration, or unfortunately death. And this was present in around 6%, 5%, and 3% of the patients respectively. Now, I have specifically taken out data from the paper focusing on the medications and severe COVID-19 outcomes, because I often get these questions in clinic, and I felt that this may be the highest yield data from the paper that may be of interest to the audience today. And I can certainly address other questions as they arise from this. So what's shown here are 3 bars. And if you go from left to right, the shortest bar is of patients on TNF antagonist alone, which is called as monotherapy. Next to it is the blue bar of patients who are on athiopurine alone, which is either azathioprine or 6-mercaptopurine. And then to the far right is combination therapy, which means both of these are being used together. Now, comparing the short bar, and take the short bar as the sort of the standard comparison here. So then we first looked at thiopurines used alone and showed that there was a 4 times risk of severe COVID-19 if you use thiopurine alone. And what is severe COVID-19? Again, to remind you, it is requiring an ICU stay or requiring mechanical ventilator usage or death. So there was a 4-fold risk of this outcome with this medication, thiopurine, when used alone. Now, next, they looked at using a TNF-alpha antagonist and combination therapy against use of a TNF-alpha alone. Here again, the risk was about 4 times. So what was the take-home message from this particular comparison? Since the rate was around 4-fold risk with both thiopurines used alone and in combination with TNF-alpha antagonists, this would suggest that the risk of severe COVID-19 appears to be primarily driven by thiopurines, and this is consistent with prior data of increased risk of viral infection with this particular medication category. Next, they looked at the non-immunosuppressive medication, which is mesalamine and sulfasalazine. And I want to point out this is somewhat controversial, and I'm sure you'll have lots of questions at the end of this talk. What they showed here was they first looked at this medication against use of mesalamine or sulfasalazine alone, against no use of this medication, and showed that maybe there was a 70% increased risk of severe COVID-19 with this medication. Next, they compared this to use of a TNF-alpha antagonist alone and showed that there may be a 3.5 times risk or 350% increase in risk. That said, when they looked at the combination of mesalamine plus a TNF-alpha antagonist against just TNF-alpha antagonist, this risk, while it may look like it's high, actually crossed the number 1 if you look at the spread of the data. Hence, there was no increased risk seen with this medication. And they also looked at a higher dose of the medication versus a lower dose, and again showed there was no difference here. So the take-home message from this particular medication comparison was there was no clear increase in risk of severe COVID-19 using mesalamine or sulfasalazine when used with a TNF-alpha antagonist. Additionally, there was no difference based on a higher dose versus lower dose. These 2 data points specifically would suggest that what we are seeing here is not suggesting a increased risk of mesalamine or sulfasalazine causing severe COVID, but more likely possibly a protective effect of TNF-alpha antagonists, especially when used alone. And that protective effect is making this medication look like it's actually causing bad outcomes. And I'm sure you'll likely have more questions on this, and I'm happy to take more questions at the end of the talk, trying to talk about this data. So next, they looked at a couple of other newer medications. One of them is this drug ustekinumab or Stelara, and then compared that to TNF alpha antagonist when used alone, and showed that there was no difference between the groups. So Stelara was no more likely to cause severe COVID compared to a TNF alpha antagonist when used alone. Same thing was the case with vedolizumab or Entyvio. Again, here the number looks like 2.42, but if you look at the spread of the data, that includes the number 1. Hence, this comparison also, there was no increased risk of severe COVID with vedolizumab or Entyvio. And that's really was a take home with this particular comparison. Finally, we look at the use of corticosteroids. So they build a big, complicated statistical model. But what I would actually have you focus here down at the bottom, shown highlighted in red, where it looked at use of steroids alone, use of steroids versus no use of steroids, and showed that there was a 4.6 times increased risk, or a 460% increased risk of severe COVID when if a patient was on corticosteroids, even controlling for the risk of other medications used along with, or even if they had cardiovascular disease. So if you look at it, the risk of steroids causing bad outcomes with COVID-19 is more than the risk of that with someone having cardiovascular disease at the same time. That is rather remarkable. So here I have a comment here that, as some of you have probably seen in social media and print media, that dexamethasone appears to be beneficial in treating COVID-19. Now, the idea here is that being on steroids prior to the what's called as a cytokine storm or inflammation phase of COVID-19 may be actually bad, because it prevents the body from clearing the virus. But once the inflammation storm hits the body, then giving steroids at that point is likely of benefit, which probably explains why dexamethasone is useful in patients in the ICU getting that medication. So then finally, in the last couple of minutes, looking at what are the expert consensus recommendations on COVID-19. So there's a panel of experts, international, and they released a series of statements which said mainly that the risk of infection with SARS-CoV-2 is the same whether you have IBD or not. In other words, IBD itself does not appear to increase the risk of getting COVID-19. It's also not clear if necessarily there's a difference between active disease or not in terms of the risk of getting the infection. And certainly having a ostomy or a J pouch does not put you at a higher risk of COVID-19. Based on the secure data, greater risk of severe COVID appears to be, like in the general population, older patients or diabetes, and certainly if they have use of steroids, as we showed a few slides earlier. Sorry, I just skipped a slide. Additional statements were, and I advise my patients this, that if you have IBD, you should be careful about travel, and obviously travel only if you really need to. Otherwise, obviously social distancing would be of benefit. And it is certainly safe to continue getting infusions in an infusion center, which has a screening protocol like we have, and I'm sure other centers have, but we ask questions about active COVID-19 symptoms and only admit to the infusion center if there's no active symptoms. So this is kind of a complicated slide to end this with, but basically says that if you have no symptoms, ideally you should not be getting tested and should not hold therapies. Now, if some reason you don't have symptoms, but you yet got tested and found to be positive, ideally it's recommended to hold therapies for about 10 days. And if no symptoms at that point, restart therapy. Now, if you have symptoms and got tested positive, then ideally it's recommended to hold therapy. And the most common strategy done is to wait for 10 days until the symptom onset before restarting medication. After also ensuring that you're at least free of key symptoms such as fever for at least 72 hours or 3 days without using things like Tylenol, and there's obviously no active cough or shortness of breath. In that case, it's okay to start therapy, restart therapy if 10 days have passed. So that's sort of the usual recommendations. Now, some places may use a testing strategy to restart therapy, but that's not very common. So to summarize here, GI symptoms can be frequently encountered with COVID-19. The virus may be detected in stool, although it's still not clear if it can be necessarily transmitted by a fecal-oral route, because you may find the virus, but it's most likely dead virus in the stool. We encourage our IBD patients to continue on current treatments, including the mesalamine and sulfasalazine, with the exception of steroids. Now, if you have a flare, of course, you should get steroids, but we always try to get patients off of steroids as soon as possible. If you have active COVID-19 infection, certainly the immune suppressive medication should be held, and then restart usually around 72 hours after the fever is no longer present without the use of Tylenol, and at least 10 days after the onset of symptoms. With that, I'll stop here and I think proceed with other speakers. And then my understanding is there'll be more questions I can take from the audience at the end of the other two speakers once they've done. Thank you.
That's correct. Thank you, Dr. Deepak. And I just put a note in the chat that we can, that folks that have questions can type them into the Q&A box at the bottom of your screen. Next, I want to introduce Dr. Faiza Bhatti. She has recently returned to St. Louis to us from Henry Ford in Michigan, and she is currently a gastroenterologist at Mercy Hospital South. Dr. Bhatti, I see you have your slides up, and the virtual stage is yours.
Thank you so much for the kind introduction, Dan, and great job, Dr. Deepak. I loved your presentation, very concise and to the point, and it was very, very informative. Good job.
Thank you.
So the topic I'm talking about tonight is pregnancy and IBD, which is close to heart, and I think it is a very important topic that we discuss with our patients when we see them in the clinic. As we know that incidence and prevalence of IBD is on the rise. I have a data which is at least 5 years old now, but the total cases of IBD in America were in 2004 were 2.7 million, and now we have 3.9 million cases of IBD in America, which is the data of 2015. And unfortunately, the peak time of the IBD diagnosis coincides with the reproductive age. So that means a lot of younger population have to deal with IBD during the prime time when they are thinking about starting the family or getting settled down, and they are hit with this severe disease. So this is the topic I'm going to talk about, making it very patient focused, that there are a lot of misconception out there which needs to be debunked, and there are many things we can achieve. Having an IBD does not mean that you cannot get pregnant or you cannot have kids. So this is what I'm going to focus today. So I have no disclosure. So when I see patients in my IBD clinic, a lot of questions that get asked, especially if they're new diagnosis, if I'm seeing if a post-teen kid in a 18-year-old kid in my clinic, or early 20s, and they're coming with their parents, they are more concerned about the effect of this disease on their fertility and having kids than the disease itself. So these are the few questions we get asked, that should I have children? Should I get afraid of getting children? Am I going to transfer this disease to my kids? And what is the best time to get pregnant? What if I get pregnant and I have bad disease? How are these medications going to affect my pregnancy? How are these medications going to affect my baby who is in the womb or who has been born for their lifetime, not only in their physical health, their immunity health, but also their mental health? And how does it affect if I'm nursing my child? So all of these questions I'll try to answer tonight. And if you have any more questions that I don't hit, please feel free to ask. And so one fact which has proven many times that IBD does not affect fertility. Having IBD does not make you infertile, does not make you less likely to have a kid, unless you have undergone surgery of the abdomen, which may affect it. But if you have a quiescent IBD disease, it does not decrease or increase the risk of fertility. Now, inflammation associated with the Crohn's disease, because as we know that ulcerative colitis tends to stay within the colon, but Crohn's disease tends to try to get out of the colon. And if there is an inflammation which is through and through the bowels and affecting the organs, as we know that the colon, the rectum, and the ovaries, fallopian tubes, they all are very close together. So if there is an inflammation, there is a hostile environment because of Crohn's disease in the pelvis, and there are some adhesion, some blockage, then it can definitely affect the risk. So having a quiet IBD does not affect the fertility. So the key is keep the disease under control. If you are planning to have kids, the best thing you can do is to keep your disease under control to have better outcome, not only for the disease, but also for your pregnancy. Now, I check this. This is a molecule or enzyme that you check in patients who is going to have problems in the fertility if they are 35-year-old plus, 38-year-old plus, and they're having difficulty in conceiving the child. Then I usually check the AMH level, and if it comes down low, I usually refer them to the fertility clinic. Now here in Missouri, I'm new, I'm trying to learn my resources around, but back in Henry Ford, we had a multidisciplinary clinic where we were referring patients. So I'm sure bigger center like WashU and SLU, they probably collaborate their work with the OB. They play a huge role in the patients who have IBD and they're pregnant. And now, volunteer childlessness. It's very sad to see that a lot of my patients who come to me, they don't even want to talk about getting pregnant because they just are so afraid that I don't want to have kids. I'm suffering so much. I don't want in my dream to give this to my child. So this is what I really want to discourage, that pregnancy is a beautiful thing. Having kids is a blessing. If you have IBD, by no means you should feel that you are going to do a harm to your child. Thank goodness we are living in 2000. I mean, not this year is the worst year. Not that I'm happy that we're in 2020, but we are, if I talk about 20 years ago, when we had no biologic except infliximab was getting approved, that was a time when having Crohn's or ulcerative colitis was difficult. But now we have so many options medically and surgically, non-invasively, robotic surgeries, that there is no way that you should think that having an IBD bar you from getting married or from getting settled down. Go ahead, have as many kids as you want, but please keep your disease under control. Now, a lot of times our IBD patients have malnutrition because of either their disease is not under control, or if they have small bowel Crohn's disease where all the nutrients get absorbed, they have deficiencies of a lot of other micronutrients that can play a role in making their chances to go down in getting pregnant. Low zinc, low vitamin D, having a celiac disease or having another autoimmune disease can affect the risk of having infertility. So now, you can divide the natural history of IBD into two eras. One is before the surgery and the second is after the surgery. So if I divide, like, what are the chances that is going to affect my fertility if I have IBD, then not having a surgery definitely is helpful. Now, if patient have ulcerative colitis and there is a surgery that is done for the ulcerative colitis patients, which is we call J-pouch, which is you take this whole colon out and they have this ostomy temporarily, and then this small intestine is connected to the rectum, which we call the J-pouch. So having a J-pouch, you can imagine a lot of dissection is being done in the pelvis. So a lot of times we recommend people that if they have ulcerative colitis and the disease is not under control and they are heading towards a surgery, then it's better to get an ostomy, and before they undergo J-pouch, have 10 kids, and then go back to the surgeon to get you connected for the J-pouch. So not that I want you to have 10 kids, but the fertility goes definitely down after going through the J-pouch, because the data clearly says that half of the patient who undergo J-pouch will have problem in conceiving child is because of the scarring in the pelvis, because the transfer of the ova or the egg into the uterus is affected, because the migration through the fallopian tube is affected. And ileostomy is such a cosmetic concern that a lot of times patients are worried that I have a bowel sticking out of my gut. If I get pregnant, where the baby is going to find the space and how it's going to affect my ostomy. So it's better to delay the J pouch. And if there are data about pregnancy and ileostomy as well. But it is very important to understand that, yes, having a J pouch reduces the fertility. I also recommend my young patients to think about banking their eggs if they are in 20s and they don't want to get pregnant, or they are not ready to get pregnant because of their disease, because of social or economical decisions. Then banking their egg early on is also helpful, because as we know, the biggest factor to decide fertility is the age, nothing else but the age. After 35-year-old, we are born with certain numbers of eggs. As we grow older, the chances of getting pregnant goes down regardless if you have IBD or non-IBD. So if you think about it, then I think it's a smart idea. I always recommend my IBD patients that if your disease is quiet, is in remission, go ahead, get pregnant. And if you don't want to get pregnant, go bank your eggs so you can use them for later. Just something to think about. There always, when there is a will, there is a way. Just don't get discouraged. And this data is again indicating very clearly. So the blue bars are patients who don't have IBD. The red bar is the one before any surgery for IBD. And the green bar is the one when they have had their surgery. So you can clearly see, no matter if they have IBD or not, the fertility goes down as they cross the age. So 35 is a magic number. That is the biggest factor which will decide about your fertility. And definitely having surgery does affect it, but age is the biggest factor. Now, J pouch definitely reduce the fertility, as I have mentioned it already, that half of my patients who undergo J pouch and they are in their young reproductive age, I clearly tell them, but then it becomes the choices that we make. Am I going to risk having a severe ulcerative colitis and delaying my ulcerative colitis surgery and get pregnant when my disease is not under control? That's not a good idea, because I'm going to discuss in a few slides down the slides that having a bad, severe, uncontrolled disease affect pregnancy way more than the disease or medication itself. So it's the choices that we make, and the decision should be mutual. Not only your IBD doctor, but your OBGYN, your partner, your family, they all should be involved. And you should never feel overwhelmed by feeling like I had to take this big decision by myself. And I think all of our IBD, I always say that I'm biased, but I think our IBD doctors are very involved in their care. And that's why we are IBD doctor, because we all knew it before picking up this field. This field is going to require a lot of handholding, a lot of hugging, a lot of counseling that comes with this. But we chose to be IBD provider because we have that in us, that we are going to make difference in your life. So when I see a young couple in my clinic, the first thing I give them is the hope that you are going to do okay. We are here with you. We're going to walk with you. So just stay hopeful and stay positive. That's the only thing that is going to make a huge difference. Now, how about what kind of surgery? So J pouch is the biggest surgery that we have in the field of IBD. Perirectal anastomosis, perirectal abscesses, those are small surgeries. They don't affect the fertility, but having the J pouch is one of the biggest surgery. So laparoscopic versus open. It's important that if you are taking a decision for undergoing a ulcerative colitis surgery, or your IBD doctor is recommending you that you should consider total colectomy followed by J pouch, you should go to the center that have a qualified colorectal surgeon who has had done many J pouches. So you should go to the qualified surgeon. And laparoscopic surgery, that means less cut, smaller adhesions, a smaller scar, and less inflammation after the surgery. So definitely we recommend, and a lot of surgeons are only doing laparoscopic. They are not doing open, but some cases you have to do an open J pouch. So go to the place where you think the surgeon is qualified, do your research, because laparoscopic J pouch has less chances of reducing the fertility than the open J pouch. Now, what about the mode of delivery? You have had a great IBD doctor, your disease is under control, you are in remission, you decided to get pregnant, and now you are pregnant. So how about the delivery? Should every IBD patient go and get a C-section? So no, the only indication of having a C-section for the IBD patient is active perianal disease. Not that you have history of rectal abscess and you had like the ceton placement years ago, but now you have completely quiet and no activity in the perianal area, then there is no reason for you to electively choose C-section. You can definitely go through natural birth, but I have had patients who had active Crohn's disease. They had like fistulas, they had like pus pouring out from them, but they still wanted to consider a vaginal delivery. So no brainer, common sense. If you have an hostile perianal area, and if you're going to go through vaginal delivery, you never know if your labor is going to be 2 hours or 48 hours or 36 hours. So you're going to expose your perianal area to that prolonged stress and inflammation and the pressure that if the fistula was there, it may get bigger, it may tear, it may turn into a rectovaginal fistula, and that's a nightmare. So we tend to convince our patients, but I have had patients who refused to undergo cesarean. They wanted to do natural birth. So again, it's a choices that we make, but otherwise there is no reason. If you are quiet ulcerative colitis disease, there is no reason for you to consider scheduled C-section. There are more risk of fecal incontinence after the prolonged labor if the patient have perianal disease. How about postpartum fiasco? So I have 3 kids of my own, and I'm sure a lot of you have had the blessing of having kids. So we all know that pregnancy is beautiful, everything looks great, but after, when the baby is out, holy moly, nobody told you about those sleepless nights, right? Nobody told you that there will be fights among partners. Who's going to change the diaper when it's 3 a.m. in the middle of the night? So stress has a lot to do with IBD flares. But the beauty of pregnancy is that during pregnancy, we have a hormone, progesterone, which is produced in high quantities when we are pregnant. And progesterone has natural anti-inflammatory effect. So when you're pregnant, a lot of my patients do wonderful during pregnancy. Their inflammation goes into the quiet phase just because the progesterone effect of anti-inflammation. So once the baby is out, that means the mother nature is taking care of you. That you're pregnant, I'm going to give you a ton of progesterone, your inflammation is going to go down. But once the baby is out and progesterone hormone goes down, then within the 6 weeks of baby delivered, you are at risk of flare. So keep that in mind. A lot of my patients, when they come to me in 2nd trimester and 3rd trimester, and they're like, you know what, this is the best I have felt since I have had IBD, because I don't have any symptoms, I feel great. So I always warn them that I'm glad you're enjoying it, but be ready that within 6 weeks of the baby delivered, you are at risk, especially ulcerative colitis tend to. We don't know why, but the data suggests that ulcerative colitis can develop a flare after the baby is born. And if they have a J pouch, 30% of the patient can develop dysfunctioning of the J pouch. Their J pouch can flare, they can have pouchitis after the baby. So we have to be careful about it. And that's why keeping the disease under control around before conception, during pregnancy, and even after pregnancy. So once the baby is out and you're too overoccupied by taking care of a newborn, or if you have twins, don't forget to go and see your IBD doctor soon after the baby is born, so they can check if you have active disease, and if something is needed to be done, that should be done before it's too late. Now, how about the transmission? So this is the biggest question that I get a lot, that what are my chances that if I'm going to give it to my baby? Fortunately, there is only, I can see this data is out there, it's old, but nothing has changed. So only 5% risk of you giving IBD to your kid if you are the only one among 2 partners who have IBD. So look at the 95%. Don't look at the 5%. Look at that more than 95% chances that you are not going to give this disease to your child. So there is no reason for you to fear. Now, if one parent has IBD, the risk is up to 13%. But if both parents have IBD, yes, that means you are giving a genetic profile that is prone to have autoimmune diseases. So yes, and Crohn's disease has more risk of getting transferred than ulcerative colitis. And the highest risk is if mom has IBD and she's having a baby girl. So that is the highest. But again, this should not matter. We have a great field of IBD research. We have great options that should not scare you at all. And how about the fetal outcome? So we all know that just having an IBD, not active, not quiet disease, but having an IBD generally tends to lead the risk of having a preterm delivery, having a low birth weight, and having a small for gestational age. That means there are risks. And don't forget that with the medications, we are suppressing the inflammation, but this is a disease that remains with you. It's kind of like living with a monster that you are never going to get rid of the IBD, which is very depressing. But again, if you take your medications, it stays under control, but there is a chronic state of inflammation that reduces the healthy nutritional status that can lead to all of these risk factors. So, and on the top of it, if you are having an active disease, all of these risks will just go up. So again, key is listen to your doctor, listen to your dietitian, listen to your nurse practitioner or mid-level, keep your disease under control if you are planning to get pregnant. How about medications? So we have a ton of medications available, which is a good problem to have, that we can pick and choose, and we can draw a full diagram to choose from the medications. And thankfully, majority of the medications, actually all of the medication except methotrexate, are safe during pregnancy. Methotrexate is an immune modulator, which is not even given to the young female who are in reproductive age. And even in male, if they're taking methotrexate, they need to hold it for 3 months before they start trying to get their partner pregnant, because it can reduces the speed of sperm. So it kind of like same thing with sulfasalazine, that you should stop it 3 months before you start the planning. That female definitely contract. We don't even choose to give it to them unless there is a major emergency and there is nothing else. Now with so many options, it is like an old story that people were giving methotrexate to young female if they had no other options left. But then you have to be on 2 different kind of contraception to make sure, because it is a teratogenic and it can lead to severe malformations in the fetus. So female, young, you should not be on methotrexate, period. And thiopurine, so Imuran, which is azathioprine, is used in usually in the combination. It is usually used for the ulcerative colitis and Crohn's disease when they are on biologic agents for several reasons. Now, we have a huge data from autoimmune hepatitis. The use of azathioprine was first reported in the autoimmune hepatitis. So a lot of the data is extrapolated to the IBD population. So it's an anti-metabolite. It reduces the formation of hemoglobin. So all the babies who are born to the mothers who were taking azathioprine, they all have anemia, which usually corrects within 3 months when the baby is out. So it does not lead to any problem, but it does not cause congenital abnormalities. It is safe during pregnancy, safe during lactation. So it is also safe. But one thing that I remind my pregnant patient, I usually like to see them every 4 weeks when they're pregnant. So when they're coming to my clinic, the only thing I remind them that after the baby, they can get all the vaccination except the live vaccine. And in America, the only live vaccine that is given to the newborn is rotavirus, which is given at the 1st month appointment. And pregnancy brain, we all know that how many things we forget when we are pregnant. So I always remind them in every visit. I remind them to the partner, I remind them to the mother, the neighbor, everybody that 1st month appointment, don't you dare getting rotavirus because it's a live vaccine. And if the mom was on immune suppressive therapy during pregnancy, like infliximab, adalimumab, which is Remicade, Humira, or azathioprine, and they're pregnant, they stayed on these medications, then the baby cannot have live vaccine up until the age of 6 months, because those medications get transferred to the baby's blood. All of the babies who are born to the mothers who are taking these medications, they will have those medications in the bloodstream. So the only is Rota. Oral polio is not given in America, so we don't have to worry about it. BCG is also not given in America. It is given in South Asian countries. So those are the 3. But for you guys, for American patients, rotavirus is the only thing. They can get it after 6 months, and it is given to prevent the infectious diarrhea in the newborn. So it's important, but they can get it once they are 6 months old. FDA drug label has changed. Before they were like category A, category B, category D and X, but now we have taken it off. So now if you look at the package insert, they talk about pregnancy separately, they talk about lactation, and they make it more easy for patients to choose and pick from. Because if you look at the previous label, azathioprine was labeled as category C, which is not correct, because then the patient comes to me that it is C, why are you giving it to me? No, it is not C, it is B. So it's kind of like confusing, but we don't have to worry about it anymore. Okay, so quite a lot of data on these medications, and no risk of congenital abnormalities have been reported on either one of these medications except methotrexate. So rest assured, keep on these medications. You're not going to harm your baby. You're going to harm the baby if you don't take your medications and get the disease activity. That is going to be worse than the medication itself. Now, what happened to the medications that we take, especially talking about infliximab, adalimumab, like Remicade, Humira, Simponi, and Cimzia? Those are the anti-TNF, and they all are IgG-based antibodies. And IgG is an antibody that freely cross the placenta, and the transfer of those antibodies increases as the pregnancy progresses. So you can see this is the gestational week. Week 20, the transfer of those antibodies is near to zero, but as the pregnancy advances, the transfer of these drugs increases. So infliximab, Remicade, Humira, all of these medications will be transferred freely to the baby, but again, does not cause any problem. So it's okay for them to have those medications in the bloodstream. How about the outcome? So Piano registry was the biggest registry for the pregnant patients, and we have data from it that outcome in the patients who have anti-TNF in the cord blood was as same to the patients who were not having it. And of course, infliximab and adalimumab, Humira and Remicade, those are the medications or IgG-based antibodies. So if the mom has it, the kid will have it, and it will have it for at least 6 to 12 months. Now, ustekinumab, vedolizumab, natalizumab, and certolizumab, these medications, certolizumab especially, it's the Cimzia that does not have a factor that transfer the drug into the mother, into the baby. So Cimzia, if mom is taking Cimzia, certolizumab, the infant does not get any of the drug because this drug does not cross the placenta. So out of all the anti-TNF agent, certolizumab is the only one that does not cross the placenta, but it's not used as much. Ustekinumab, vedolizumab, they also do not cross the placenta as much because they are not IgG-based antibodies. This anti-TNF are the one that we worry about. Piano registry again, there was outcome of seen with preterm birth and the disease getting reactivated in the 3rd trimester, but it was all based on patients who does not have a disease better controlled during a pregnancy. And it's all about timing, that if you're planning to get pregnant, how your disease is behaving at the time of conception, that's the key. It's like 1/3, 1/3, 1/3. That means if 100 patients were going to get pregnant, if their disease was under well control and they had not problem, then most of the time their disease is going to stay in remission throughout the pregnancy. But if their disease was horrible at the time of conception, then their disease is just going to get worse during the pregnancy. And other third did not have any difference of the pregnancy. So I always tell my patients, I tend to get really involved in their personal life. I tend to be very protective and kind of like unwanted mother-in-law in the scene, that you have to call me when you're trying to get hook up your wife, okay? You have to get my permission. You have to get my blessing that if she's ready to get pregnant or not, because I'm a selfish doctor. I care about my patient more than anything else. So if her disease is under good control, then go ahead and knock her up tonight. But if they are not, then I give them, but take maybe 4 more months, take maybe 3 more months, so we can do something to bring the disease under control, and then you're allowed to get pregnant. And if you are pregnant and you are on infliximab or you are on adalimumab, then usually it's a 32 weeks of gestation when we say that hold off, take the last dose of infliximab. C-section is a major surgery. So infliximab and anti-TNF agents have not been reported to increase the risk of infection after the surgery. It's the use of prednisone, use of steroids before the C-section. So that increases the risk of infection. So another reason to keep your disease under control, because if you're going to need steroids because your disease was not under control and you are undergoing C-section, that is a double whammy, that you are increasing the risk of not only to the baby, but you're also increasing the risk of yourself by the skin infection due to steroid on board. So infliximab and adalimumab are safe. Usually it's the 32 or 34 weeks when we say to take the last dose, and then they can go ahead and get their delivery. Again, I have to keep picking up my Henry Ford experience that we used to give the infliximab infusion right after their delivery. So we used to make arrangements that if the patient is getting vaginal delivery and they're due for their infliximab, we were making arrangements so they can get their infusion and then they go home, so they don't have to worry about another infusion for at least 2 months until they're busy with the baby. And adalimumab, they can take it home by themselves, so that's not a problem. But leaving a baby, especially in winter of Michigan, that we try to not have them leave their house for unnecessary reasons. And management of flares. So now, may God forbid, you were doing great when you were not pregnant, and now in the middle of the pregnancy, you got either infection or you underwent a flare. So how do we treat it? We treat it exactly the way when you were not pregnant. So same thing, low threshold of using steroids. You still can get an MRI. CT scan usually is not recommended, especially in first and second trimester, but we can use steroids and low threshold. So what I do when I see my pregnant patients, I check the stool test, the calprotectin, which is a very sensitive test for the indication of the inflammation of the colon. I check it every trimester, first trimester, second trimester, and third trimester. And anytime it is crossing the normal line, we give them steroids to bring the disease under control. So low threshold, treated exactly the same. If they have Clostridium difficile infection, which is a higher risk for IBD patient, we treat them exactly the same. So no difference. We try to avoid doing any endoscopy, but unsedated endoscopy still can be performed with a fetal monitor. I have myself done unsedated endoscopies in pregnant patients just because I had to rule out CMV colitis, or I had some other reasons to do endoscopy. So it can be done. Even sedation with propofol can be provided. It's not dangerous, but we like to avoid it. So quick 5 minutes flexible sigmoidoscopy unsedated can be performed pretty safely with fetal monitor. So there is nothing, if you need it, you need it. And surgery can also be done in the second trimester usually. So very quickly going through this slide, that it's the preconception, which is very important. Counseling before you're getting pregnant. So we used to send them into the preconception IBD clinic where I was at Henry Ford. That's what my dream is, to make the total IBD care for Mercy South as well, that we have an IBD center that have everything under one roof, where they can have preconception counseling, they can see a dietitian, they can see a behavioral health in the same setting. So preconception education about taking care of themselves, taking multivitamins, taking folic acid, and keeping their disease under excellent control before getting pregnant is the key that will take you far and will take you to the finish line with safety. First trimester, again, same thing, continue medication. Do not stop the medication. Even your OB is not comfortable using azathioprine during pregnancy, do not stop the medicine. Always consult your IBD doctor. Just don't go to Dr. Google, look up something and get scared that somebody said, oh, I took azathioprine and my baby got heart defect. No, that's not true. Verify. Internet is a crazy space. You can find anything you would like to. So please confirm with the doctor first. Talk to your OB and make sure your IBD doctor and OB doctor are talking to each other. So if there is any misconception on the OB side, that can be cleared. If there is a misconception on the IBD side, the OB can clear. So in communication amongst the provider is important, and you doing the right thing for you and your baby is important. So in short, women with IBD are at risk of pregnancy complications and adverse outcome, no doubt about it. That's why it's more important that you're taken special care of when you're pregnant. Active disease is the greatest threat to the baby, more than the medication itself. With exception to methotrexate, all the medications are safe. Thiopurine, if you're concerned about anemia in the baby, then maybe you can stop thiopurine during pregnancy. But if you are on other biologic agent along with it, if you are on anti-TNF and you don't want to be on azathioprine because of the immunity and the baby's risk of infection, which has actually have been proven that there is no increased risk of infection. But if you're really anxious, then okay to take off thiopurine if your disease is in remission and you are on some other agent that's going to keep your disease under control, just do not rock the boat. If boat is sailing, let it sail without any trouble. And counseling, of course, is, as I said, is very important, and close monitoring by the multidisciplinary team is very important. Talking to the doctor and making sure that your providers are talking is important. Pregnancy is beautiful. Everybody should have babies, and having IBD should not stop you from getting scared of pregnancy. So I was happy to present this tonight. This topic is very close to heart, and I hope you guys learned something good here. If you have any question, I'll be happy to answer that.
Thank you, Dr. Bhatti. We really appreciate your presentation tonight, and we're getting some great questions in the Q&A box. So and Dr. Deepak has gone and answered several of them. So if any of you have any questions for Dr. Bhatti on IBD and pregnancy, feel free and type those in. Next, I'm going to introduce Kristin Cunningham with Washington University School of Medicine. She is a dietitian at the IBD Center there. Kristin, welcome.
Thank you. Okay, we're getting it sorted out. Bear with me.
No problem at all. Take your time.
Okay.
Okay, we can see your screen now.
Wonderful. Okay. I'm very happy to be here, and I can see by the time that I'm going to do a kind of a condensed version to leave plenty of time for Q&A here. But just so you are aware, I am a dietitian at an outpatient center at Washington University in the Inflammatory Bowel Disease Center, and I work with adult patients. And here's what my plan was for today. First, I want to introduce some new diet guidelines that I think patients and families should be aware of. And boy, the past 7 months have been tough times for all of us. So I thought I'd keep it kind of light and focus on food and some practical information about diet and IBD. And then finally, I'd like to share some of my favorite diet and recipe resources with you. Okay, so these are the new guidelines that I want to make sure folks are exposed to. So Dr. Deepak had referred to the IO-IBD in one of his slides. And as you can see, it's just an acronym that stands for the International Organization for the Study of Inflammatory Bowel Disease. And for the first time ever, they took a subgroup who were focused just on the topic of nutrition and IBD, and opted to come up with these guidelines. And before I dive into the details, I'll just kind of pro-con this for you. So the pro is that this expert group has decided to devote time and energy to reviewing the available research on diet and IBD and trying to come to a consensus. So that's a big win. And in terms of the con, so there is limited available research on diet and IBD, and the studies that do exist, some of them tend to be maybe not of the best quality or perhaps focus on animal studies instead of humans. And so I think the one important takeaway point is that the recommendations are based on somewhat weak evidence. And I think that's an important thing to keep in mind as you make decisions based on these recommendations. So if we look along the top side of the chart, you see there's a green arrow up that's suggesting these are the things that would be maybe beneficial to increase. You'll see for Crohn's disease, they recommend increasing intake of fruits and vegetables. And for ulcerative colitis, they suggest increasing intake of omega-3 fatty acids, and you'll notice that they say from fish and food. So there are omega-3 fatty acid supplements available, but they're very clear with the research that they did review that the benefits are seen when the omega-3s are coming from food sources. And so along the right side of your screen, in case you are not familiar with food sources of omega-3s, I've listed sources from fish and also plant-based sources for you. In terms of those that they suggest to decrease, so ingredients of concern, the top 2 bullet points under ulcerative colitis are unique to ulcerative colitis, so I'll cover those first. The first bullet point suggests red meat and processed meat, and what they were primarily referring to is red meat that is grain-fed. So grass-fed tends to be higher in omega-3 fatty acids and is looked upon more favorably, but grain-fed red meats are thought to be possibly problematic. And then the next bullet point says dairy fat, palm, and coconut oil. What I think is the biggest takeaway here is that some of my patients see that word dairy and they think, well, I've got to cut out dairy. And I certainly don't want you to walk away from this presentation thinking that is the case. So it is not all dairy that is thought to be problematic with ulcerative colitis, only dairy which has a high fat content. So we're talking things that are cream-based, whole milk, and products that include those as ingredients. The remaining bullet points are the same with Crohn's and ulcerative colitis, so I'm going to kind of cover those in tandem. So saturated and trans fats are on the list for both Crohn's and ulcerative colitis as ingredients of possible concern. Possible concern. Next is emulsifiers. So these fall under that category of food additives. And you'll see on the left-hand side of the screen, I've identified 2 emulsifiers you may see in ingredients list, carboxymethylcellulose and polysorbate 80. The next thing on the list is carrageenan. That is a seaweed derivative. And that sounds like kind of a strange thing to add to food, but all of these things that you're seeing are primarily used to extend the shelf life of foods. And carrageenan tends to do a pretty good job of keeping foods like mixed together, even if they sit on a shelf for a while. Artificial sweeteners, and they have focused on 2, sucralose, which is the primary ingredient in Splenda, and saccharin, which is the primary ingredient in Sweet and Low. And then maltodextrins, if you don't currently look at ingredients labels on foods and you start doing so, you're going to see maltodextrin everywhere. It's incredibly prevalent in the Western diet and packaged foods. And then finally, titanium dioxide, which is considered a nanoparticle, and that's primarily used to add like a bright white color to particular foods. You will notice at the bottom, I provided the source. The paper provides much more detail than I've just provided you with, but I think that's a pretty decent summary. I will quickly click through just the next few slides to show you some examples, and then I think we'll probably be about ready for some Q&A time. So here's an example. I'm not here to burst anybody's bubble tonight or judge any food choices. So Ben & Jerry's ice cream, you'll see, has several of those ingredients of concern. So carrageenan, it is a dairy fat-based product. It's made from cream, which means it's also going to be high in saturated fat and contains trans fat as well. The next one, some brats. So it's a red meat. This is a grain-fed animal source. And it is processed and has a high content of saturated fat. And we'll do just one more. Little Debbie fancy cakes. So they have palm oil. They contain polysorbate 80. Remember, I said that titanium dioxide provides that like bright white color to foods. I can almost guarantee it is used in the icing and the cream filling to give it that pop of white. And it has saturated and trans fats too. So where I'd like to kind of summarize this is what is the takeaway of this. I've already mentioned it's based on weak evidence, although it's good to have these recommendations. So where does that leave a consumer with IBD? My personal takeaway is that if you focus on the items to increase, so fruits and vegetables if you have Crohn's disease, omega-3 fatty acids if you have ulcerative colitis, and then as far as the ingredients of concern, you'll notice that most of those are going to be found in really highly processed packaged foods. So limiting those kinds of foods in your diet will naturally limit your exposure to those ingredients of concerns. Having a little Debbie fancy cake from time to time is not going to make or break your overall diet. So I certainly don't think you have to see this as a list of things to eat or not eat. But I think it can be helpful for you to start reviewing ingredients list and start to see maybe where some of those items are, and just kind of do a mental tally. If you think of the day before and you had 3 or more things that were highly processed packaged foods that contain some of those ingredients, you might want to look for some ways to find some alternatives to replace those. So I did have some recipes and pictures, but Dan, I might leave it in your hands if I kind of thinking I should maybe stop here.
Kristin, I think you should continue. I think the recipes are going to be great, and the questions we've gotten so far have been answered in real time in the Q&A box. So feel free and continue.
Okay, thank you. Okay, so now on to the more fun part, the eating and food. It's always a party. So let's take a look. All I did is, most of my patients, what they consider to be a pretty valuable tool is just to have an idea of a sample menu. So really practical terms, what do some of those guidelines look like in play? So that's what I did. So if we start with breakfast, I did a spinach and egg omelet, some cherry tomatoes with parsley on the side, a banana, and some modulin, which for those of you who are watching tonight, if you're not familiar with modulin, it is a Nestle product that it has been available in Europe for quite some time, but it has just returned to shelves in the United States. So it is intended for people with IBD, and if you have not tried it, it might be worth a try. And what I attempted to do here is for each meal or snack to let you know if it meets the needs of a certain diet. So you'll see that this one meets the needs of the Crohn's disease exclusion diet plus partial enteral nutrition, also known as Modulite. But it also happens to be lactose-free, gluten-free, suitable for a lacto-ovo vegetarian diet as well. In terms of ways to improve the tolerance, the spinach and parsley that were used could certainly be cooked until softer to make them a little bit better tolerated. And some of my patients struggle with tomatoes. On this Modulife diet, carrots are also acceptable, so it'd certainly be easy enough to swap out the tomatoes for some cooked carrots for improved tolerance. Okay. Next, for morning snack, I did a homemade specific carbohydrate diet yogurt with some pureed peaches on top. This would meet the needs of the specific carbohydrate diet, or NIMBLE as it's also known, or the IBD anti-inflammatory diet. It's also gluten-free, lacto-vegetarian, it's probiotic rich with that yogurt, and friendly for people who have strictures too. So that peach puree could move with ease through even a narrowed small intestine. One thing that I think is worth noting is that peaches are a high FODMAP food. Some of our patients choose to follow a lower FODMAP diet. So if you're sensitive to the FODMAPs in peaches, you could always swap that out for a lower FODMAP fruit like pureed pineapple, for example. And you'll see the books that are listed there or that appear there are both offer recipes for homemade yogurt, as does pecanbread.com. All right, for lunch, I put together some carrot and coriander soup with tuna avocado salad. These are both recipes from the IBD anti-inflammatory diet, which is out of the University of Massachusetts Medical School. And you'll see in my resources later, they provide all of their recipes for free. So anyone can get on and access those. It also happens to be SCD and nimble friendly, gluten-free, pescatarian, stricture friendly again. And if the fresh cilantro is a problem, there's no reason that can't be tossed in, cooked with the rest of the soup, and pureed along with it too. Okay, moving on. Afternoon snack with my moms. Don't eat the mums. This is a strawberry almond milk smoothie, and it doesn't fit under any particular diet, but it happens to be gluten-free, vegan, lactose-free, and also stricture-friendly. And really any milk is suitable. I just happen to have almond milk around, so that's what I used. And for some of my patients, they might report the strawberry seeds are a little too much for them to handle, but of course there are plenty of seedless fruits that could be used instead, like blueberries or something of the like. And that gets us to our last meal of the day, which is dinner. I made sweet and sour chicken meatballs over white rice. Again, doesn't meet the needs of any particular diet. It is lactose friendly, again, stricture friendly. There is one spicy ingredient in this recipe, chili sauce, which could easily be omitted. And if tomato sauce is a problem for you, then it would be perfectly fine just to leave the sauce out as well. And I got this recipe from the Crohn's and Colitis Diet Guide. So that leads us to, oh, these are all recipes I made last week too. I was eating really good last week. It's fun. Here are all of my resources. So I've already named some of these, but the Crohn's and Colitis Diet Guide is an excellent one. It provides recipes and tips. An MD and an RD both contributed to this book. What to Eat with IBD is written by a dietitian who also has IBD. Excellent recipes that I use time and again. The Eating with IBD, the Essentials, is an e-recipe book that can be obtained through the Wellness by Food website. A dietitian who specializes in IBD and a patient are part of the team that have developed the recipes and content there. The Inside Tract is co-written by a physician and a dietitian. I don't agree with every philosophy they put out there, but they've got some good recipes. On the bottom, Modulife has both a website and a app that offers some recipes. The only caveat here is that you have to be invited to access those materials by a dietitian who has been trained and certified in the Modulife diet. And so there aren't a lot of resources just as a member of the public that you can access, but I am certified. And so, you could always contact me to gain access. And then I've already mentioned the University of Massachusetts IBD, AID resources, tons of free information, and they do a good job of breaking down into phases, with phase 1 being for folks who need the most diet modification and texture modification, and then it builds its way up. So plenty of good resources there. And that'll do it for me. So I'll look forward to hearing your questions, and I will stop my share.
Kristin, actually, the first question we have for you, Crohn's disease, should the vegetables be cooked or is raw okay?
Yeah, it really depends. The thing with IBD is it can be so individualized. So if a patient has a stricture, they should absolutely be cooked. And even pureed or mashed in some instances would make it a lot easier. If a patient is having active disease, cooking it could make the tolerance better too. And if a person is in remission, most people in remission can handle some degree of raw vegetables, although there are certainly some patients who report it's still tricky even when remission is present. So I think the important thing to remember is there's no reason for us to think that that raw vegetables, with the exception of stricturing disease, worsen the inflammatory process or cause any damage in any way. So it's really more based on symptom management. How are you feeling when you consume that thing? And if it's not great how you're feeling with raw carrots, try cooking and see how it goes.
I think this next one we can give to Dr. Bhatti, but it really could go to Kristin or Dr. Bhatti. How important is diet adherence to diet during pregnancy?
Yes, I can take that answer that question. So yeah, it is very important. I cannot emphasize enough on how important is nutrition plays a role not only in the healthy baby, even if you do not have inflammatory bowel disease, but you have to remember that all the nutrition that is going through your body, that's the only way the fetus is getting the nutrition from you. So we usually recommend high protein, low fat and low carb, but protein is the one that is highly emphasized during pregnancy, and I'll have Kristin maybe add some more to it, but definitely making healthy choices in the dietitian and in the diet and avoiding processed food is important. And according to the WHO, red meat is considered as like a food that can lead to colon cancer. So we always recommend to avoid processed, especially red meat, which can lead to inflammation because the fiber in the red meat is not well tolerated by the gut mucosa. So it can lead to inflammation anyway. And being pregnant, you just don't want to cause anything that can lead to inflammation or flare. So I'm not a vegan. I don't tout that everybody should be vegetarian. I think meat is a great thing. We should all enjoy a little bit of meat here and there, but yeah, making healthy choices, high fiber, if you don't have a structuring disease, and high protein diet that should be practiced during the pregnancy, even when you're not pregnant.
Okay, and Dr. Deepak, we'll give this one to you. Are there medications that are protective against COVID-19?
Yeah, that's a great question. I think based on the data that's out from Secure IBD to this point, there seems to be a suggestion that TNF alpha antagonist monotherapy, meaning using Remicade, Humira, Cimzia, Simponi alone without any additional medication, or perhaps using a IL-12/23 inhibitor such as Stelara alone, maybe having some kind of a protective effect on risk of severe COVID. Again, this is the data looks like that based on Secure IBD, but obviously there needs to be more studies, lab-based as well as prospective trials to really prove that point.
Great, thank you, Dr. Deepak. I have one more request for Kristin to put your contact information up again. I think you can put it in the Q&A box, and people will be able to contact you there. I do want to introduce, I mentioned earlier in the presentation that we have some great volunteers, and I want to introduce Molly Hines, who is one of our support group facilitators. She is the facilitator of the St. Louis support group. And if you all have never been to a support group meeting before, it's a great way to meet other patients and who understand what you're going through and what you've been through. Molly, are you off mute? Hello.
Yes, I am off. Can you hear me?
Yes. Good evening.
Good evening.
Hello, Chris.
Hi there.
Dan asked me to come on and just introduce myself. I'm Molly. I run the St. Louis support group, and I've been the support group facilitator for, I think, 15 to 17 years. I've lost track. It's been so long. I enjoy doing it, but this is definitely a place to come. And now that we're doing it virtually, it's even better. Come check it out. You meet like-minded people that are just like you, because there's so many of you that don't want to talk about it, or if you talk to a family member or a friend and they don't get it, we're the group of people that get you and we understand you. I also have Crohn's, so I totally understand everything that you're going through. And we talk about everything: diet, drugs, colonoscopies, prep, you name it, we talk about it.
Thank you, Molly. I also want to introduce Chris Hines, who serves on our board. And welcome, Chris.
Yeah, I'm the much lesser half. Molly's the better half.
But Chris is usually with me too. He's my support system, so anybody's allowed. I encourage it. If you come to the support group, bring your support system with you so they can understand what you're going through and what other people are going through.
Fantastic. Thank you both for your years of service to the foundation. Like I said, we have some fantastic volunteers that make this whole thing go. And with that, I don't see any more questions in the chat box, so I think we will adjourn for the evening. And I want to give a huge thanks to our presenters, Dr. Deepak, Dr. Bhatti, and Kristin Cunningham, dietitian. Thank you so much for doing this tonight. You've answered a lot of questions for patients, and also I will be sending out a recording of this presentation. So if there's anything you'd like to refer back to, it will be on our Mid-America Chapter YouTube channel, probably by sometime tomorrow. Thank you all, and I hope to see you at the third session of IBD in Focus. Have a good evening.
It's a pleasure. You guys have a good evening.
Thank you.
Thank you, Dan.